This lecture will be on the hypertension pathophysiology and its complications. So these are the outline of my lecture. So we're going to talk a little bit on the pathogenesis of hypertension and then the complications and how does these complications occur in hypertension. First, before we go on into detail, so we need to take a look on the etiology of the hypertensions. So we can divide the etiology of hypertension into two categories. Number one is the essential hypertension, which consists of 90 to 95% of hypertensive cases. For essential hypertension, so we don't have it does not have a clear pathogenesis of etiological agents, but it does occur in majority of the populations. So almost 90 to 95% of people who has hypertension does not show any etiology or predisposing causes that leads to hypertension. Meanwhile, the second type of hypertension is the secondary hypertension, in which it caused by the pathology in few organs that leads to hypertension. For example, in the renals, we've got acute glomerulonephritis, in this case, it causes hypertension. And also in patients with chronic renal disease, the blood pressure control is not that good, so the patient will have hypertension. Next is the neurological disorder, for example, in patient with psychogenic disorder. So this will cause hypertension apart from increased intracranial pressure, sleep apnea, acute stress, and also including surgery stress. Next is the endocrine, for patient or person who have adrenal hyperfunction, for example Cushing syndrome or pheochromocytoma. So these hormones will increase the blood pressure and cause hypertension in the patients. Next is the exogenous hormones, for example if patient took steroids or exogenous estrogens, so this also can give rise to hypertension due to water retentions in the body. Next is the cardiovascular problems, for example in cases of coarctation of aorta, in which it will increase the total peripheral resistance of the blood vessels, so this will eventually increase the blood pressure in the body and cause hypertension. Alright, so on to the pathogenesis. So if you're talking about the pathogenesis, as I mentioned previously, you need to start from the risk factor or the etiological agents until the disease development. So you need to talk on the etiological agents and then end with hypertension, right? So that is what is pathogenesis all about. Alright, before we go into details, need to understand the control of blood pressure. So blood pressure is controlled by two things. Number one is the cardiac output, and number two is the peripheral resistance. So if there is any defect in these two component of blood pressure control, so it will cause the blood pressure which will become increase or decrease. Okay, for the cardiac output, it is controlled by blood volumes and also cardiac factors. So I mean if there is increase in blood volume, so the cardiac output will increase and cause hypertension. So in this case, sodium, mineralocorticoids, and also arterial natriuretics peptides, and all these factors will increase in blood volume due to increase in sodium reuptake at the renal. So when sodium is reuptake in the renals, so will be taken together with the water. So what it does to the body is will increase the blood volumes. Next is the cardiac factors, which controlled by the heart rate and also contractility of the heart. So if there is increased heart rate, for example in patients who always persistently have higher heart rates, more than 100 or more 120, so the blood pressure will be increased. And for contractility, if the patient is having, for example, cardiomyopathy, hypertrophic cardiomyopathy, in which the heart muscles become hypertrophied, so the contractility of the heart is increased, so this will also eventually will increase the cardiac output and soon the blood pressure. For the peripheral resistance, it can be caused by humoral or neural factors. Humoral, as the name implies, is controlled by the hormones and also all of the interleukins, leukotrienes, and so endothelins. So all of these factors, for example, angiotensin 2, catecholamines, thromboxane, trienes, and also endothelin, is a vasoconstrictor. So it will increase the vasoconstrictions. What happened in vasoconstriction? So when there is a vasoconstriction, there will be increased peripheral resistance. So then eventually we increase the blood pressure. For the neural factors, there are two types, the constrictors and also dilators. But what we are interested in is the constrictors, in which this nerve, which has the alpha adrenergic receptor, and also alpha adrenergic kind of secretions, it will cause vasoconstrictors. So again, when there's a constriction, there will be increase in the peripheral resistance, thus increase the blood pressure. So yeah, this is just a summary. So when there is an increased cardiac output, there will be increased peripheral resistance, and this any increase in either cardiac output or peripheral resistance or both will increase the blood pressure of the person or the patients. Okay, for hypernatremia, so how does hypernatremia cause hypertension? So when there is an excess sodium intake, this will what we call a hypernatremia. So mean the natrium, the sodium inside the blood is increased. So what are being absorbed or together with the sodium is the water. So water will absorption will increase together with the sodium, so this will increase the blood pressure, the blood volume. So this increase in blood volume again will cause increase in blood pressure, thus hypertension. Alright, so for hyperaldosteronism, either it is a primary or secondary hyperaldosteronism, it will increase the mineralocorticoids. So what does this mineralocorticoid is? It will cause reabsorption of sodium and water in the renals. So when there is a reabsorption of sodium and water, again it will increase the blood volume, thus increase the blood pressure. Alright, for the primary, this is just an example of primary hyperaldosteronism. I think you had already gone through this kind of cases or this kind of pathology in the GMT107, the endocrine system. So you can have a look back regarding the primary and also secondary hyperaldosteronism. So this is just to highlight to you the condition that can cause hypertension. Alright, so the next is the increased blood volume, which caused by the increased sodium reabsorption. So there are some genetic factors, the genetic mutations in the persons that can cause increase in the sodium resorption. For example, in this case is the Liddle syndromes. So there is a genetic mutation in the 16p13-p12 gene mutation. So what does this mutation do is it will dysregulate of the epithelium sodium channel or ENaC in the renal, in the kidney. So this will increase the amount of sodium channels present in the tubules. So what will happen? It will increase the resorption of sodium. So apart from sodium, it will absorb together with water. So what happens will increase the blood volume and thus increase the blood pressure in the patient. For increased resistance, for example, in cases of pure chromocytoma, this will cause increase in secretion of catecholamines. Again, You can have a look back at the GMT202 lectures of the pheochromocytoma. So what does this do? The pheochromocytoma releases catecholamines that which cause vasoconstrictions. So when there's a vasoconstriction, they will increase peripheral resistance. And if you take a look back at my lecture notes, slides previous, the previous slides, increased peripheral resistance will increase blood pressure. So this is the correlation between pheochromocytoma and also hypertension. And this one is the vascular abnormalities, which will increase the resistance. For example, patient or person who has atherosclerosis or arteriolosclerosis. So this will cause hardened small arteries. So what will happen to these arteries? It will have a narrow lumen. So when it's hardened, the lumen become narrow because of the increase in the thickening of the vessel's wall. So this will cause the vessel lumen to become narrow. So what happened in the narrow lumen? So this will increase the peripheral resistance. So the blood needs to pump harder. The heart needs to pump harder in order to overcome this resistance. So this will increase the blood pressure and cause hypertension in the patient. Alright, for the second part of my lecture is the complication and pathophysiology of hypertension. So we can see there are two major pathology that can occur in the blood vessels in a patient or person who has hypertension. Number one is the degenerative changes in small blood vessels. For example, there are two conditions that under these categories, which is the hyaline arteriolosclerosis and also the hyperplastic arteriolosclerosis. And previously in my lecture, also I mentioned about the atherosclerosis. So you need to mind the spelling, because these two things are the different type of pathology. Number one is arteriolosclerosis and number two is atherosclerosis. So there are two types of pathology. So I won't go into detail regarding the atherosclerosis because I have given a lecture regarding that. You can take a look and have a look at the lecture notes and understand the mechanism and also all the things regarding the atherosclerosis. So today we're going to concentrate on the arteriolosclerosis. So the first one is the hyaline arteriolosclerosis. So it is associated with the benign hypertension. So when we talk about benign hypertension, it means that the hypertension is not that high. The blood pressure is not that high. Okay. So you can have a look take a look back on your lecture on the physical examination in cardiovascular system. So I think that the one used already elaborate regarding the category of the hypertension. So for the benign part, for the benign hypertension, so usually we can find this hyaline arteriosclerosis in their small vessels. So histologically, you can see the homogeneous pink hyaline thickening of the arterial wall, and it's a liminal narrowing. So the narrowing is circumferential. So the thickening of the blood vessel wall is circumferential. So how does this occur? It is caused by increase in blood pressure. This will cause endothelial injury. And what happens when the injury? There will be a plasma leakage because the endothelial, the spaces between the endothelial cells is increased. So this will cause plasma leakage. So what does plasma do? Plasma will increase the extracellular matrix production and cause hyaline thickening. So this is the vessels that involved in the hyaline arteriosclerosis. You can see that at the center there, the lumen is very narrow. So it's very small lumen, almost slit-like kind of structure of shape. So this is what will cause will cause a vicious cycle. This narrowing will cause increase total peripheral resistance, and apart from that, it will also cause this is also caused by hypertension. Next is the hypoplastic arteriolosclerosis. So this one, instead of the benign hypertension, this is a more, sometimes we call it a malignant hypertension, or sometimes we call it severe hypertension. So it is associated with severe hypertension in which the blood pressure is much higher compared to the previous case. So histologically, you can see concentric laminated thickening of arterial wall and with luminal narrowing. So again, the lumen of the vessel is also narrowed in this case. So pathophysiologically, how does this happen is when there's a severe hypertension, there will be damages to the endothelial wall, endothelial lining. So these damages to the endothelial lining will cause some of the wall, a part of the vessel's wall become necrosed. So when in a healing process, it will cause increase in smooth muscle proliferation and also reduplication of the basement membrane in order to heal the necrotic walls. So due to the repetitive healing and also necrotic processes, so this what makes the vessels to become hypoplastic. The vessel will become hypoplastic in a long run cases. So again, this is actually the whole vessels. You can see there's a layering of the vessel's wall. You can see there's a lot of the nucleus encircling the lumen at the center there. So sometimes we call it onion skinning, because if you take a cross section of the onion, so it does have a whirling kind of pattern or layering kind of pattern like an onion skin. Again, this one, the arteriosclerosis, you can go back to my previous lecture to have a look in depth regarding the arteriosclerosis. For the complication of the for the next complication of the hypertension, we can see cases of left ventricular hypertrophy in patient with prolonged hypertension. So usually the left ventricular wall thickness, usually it will exceed or sometimes more than 2 centimeter, in which the normal size or the normal thickness of the left ventricular wall is around 1.2 to 1.4 centimeter. And if you weigh the heart can exceed or more than 500 grams, in which the normal heart is around 250 to 350 grams, depends on the individuals. So histologically, you can see the left ventricular hypertrophy, there will be increased transverse diameter of myocytes, which is the myocyte is the myocyte is a heart or heart muscle cells, so we call it myocytes, or sometimes we call it myocardium. This is the same. So you will see the increase in transverse diameter of the myocytes. Apart from that, there's a prominent nuclear enlargement and also hyperchromasia of the nucleus. So again, this one is compared between left ventricular hypertrophy to the normal heart. So you can see the left ventricular wall thickness is more in left ventricular hypertrophy in comparison to a normal heart. So again, this one is how you see histologically the transverse means from in this picture from right to left measurement will be increased in compared to the normal muscles. So you can see the normal myocytes or the myocardium muscles is very thin and elongated, but in the hypertrophic muscles you can see the myocyte become thickened, and apart from that, the nucleus is also enlarged and located centrally, in which in the normal myocytes the nucleus is a bit smaller and sometimes located at the periphery of the myocytes. And how does the left ventricular hypertrophy occur? It occur because, so we start, when you say about pathophysiology, you need to start with the disease first. So in this case, the disease is the hypertension. So what is hypertension? It is increased systemic blood pressure. So because of there is an increased systemic blood pressure, the heart need to overcome this pressure to pump the blood out of the left ventricles to the circulations. So what the heart need to do is to increase the contractility to overcome the increased blood pressure. So the heart will become will have to work harder, and this will cause the myocardium to become hypertrophied. So that's why you can see left ventricular hypertrophy in the patient with hypertension. For the left ventricular hypertrophic sequelae is okay. In the left ventricular hypertrophy, there will be sequelae because of the thickness of the left ventricular wall of the heart. This will cause predispose the wall, or the heart muscle is predisposed to the ischemic conditions. So when there is any kind of blockage into the coronary artery, the ventricular wall will become ischemic, and patient can present it with unstable angina or sometimes myocardial infarctions, depend on cases. So that in the yellow circles is the coronary artery that supplies. So if you compare the size of the coronary artery is very small, you need to supply the whole thickness of the left ventricular wall, in which it already become hypertrophied. So some, of course, at the center or part of the myocardium, the blood supply is not well, how you say, the blood supply, the oxygen and also the nutrients cannot reach very well because of the thickness of the left ventricular wall. Okay, left ventricular wall also can lead, so it starts with hypertension. So hypertension cause left ventricular hypertrophy, and this will eventually lead to heart failure. So just to as a revision, so this is the blood circulation. So blood circulation is we start with from the left atrium. Okay, so from the left atrium, the blood goes into the left ventricles and go into aorta. It goes into the systemic circulation, and it go from the systemic, it go back into the right atrium, right ventricle, pulmonary arteries, lungs, pulmonary veins, and back into the left atrium. All right. So in left ventricular hypertrophy and heart failure, so I usually classify the heart failure into two types: the backward failure, as a thing that occur in the red box here, and the forward failure, in which affect the structure in the green box on the right side. So what will happen is, when there is a backward failure, the first thing to occur is that there will be congestions in the pulmonary veins. So when there is a congestion in the pulmonary veins, then there will be congestions in the lungs. So when there is a congestion in the lung, patient can present it with pulmonary edema and also pleural effusions. And apart from that, if it go further backwards, it can cause congestion in the pulmonary artery and cause cor pulmonale in the heart. And cor pulmonale will eventually cause congestion of the right ventricle and also atrium, and this will cause congestion of the systemic organ, particularly the liver, in which patient can present with hepatomegaly, and then the spleen, patient can present with splenomegaly. The lower limbs can present with the pitting edema, and also sometimes patient can present with ascites or pleural effusions. For the forward failure means the circulation distal to the heart. This is caused by the reduced cardiac output, because when there is a left ventricular hypertrophy, even though the size of the left ventricular wall is thicker, but the function is not that good. So when this function is not good, this will reduce the cardiac output. So what will cause after that is it will reduce the systemic blood supply, and this will cause patient to have lethargy, cyanosis, and also clubbing due to poor circulations to the finger and also the systemic circulation. Okay, in the brain, for hypertension, we can see stroke. This is because hypertension will cause atherosclerosis, and also atherosclerosis can also cause hypertension. So it can be vice versa. But in this case, we take the hypertension first, and that cause atherosclerosis. And then when there's atherosclerosis, there will be the atherosclerosis. If you take a look back into my previous lecture, what will happen to the atherosclerosis plaque? It can rupture because of the weakening of the blood vessel wall. So when there is a rupture of the atherosclerotic vessels, so what will happen is either two things. Number one, it can become thrombotic. The platelet will try to overcome the rupture of the atherosclerotic vessels, or the vessel itself the rupture is uncontrollable and cause the rupture of the whole vessels and cause hemorrhagic stroke. So if there is a thrombosis, we call it ischemic stroke. When there is a rupture of vessel and cause hemorrhagic, we call it hemorrhagic stroke. Alright, and sometimes we can see lacuna infarct, a few millimeter size of structure in the brain. The common sites of lacuna infarct is the basal ganglia, thalamus, internal capsule, deep white matter, and also pons. These are where the vessels that usually affected by the hypertensions, and when there is this vessel is affected by hypertension, it will cause some degree of infarctions at this area. Alright. And sometimes small vessel we can see slit hemorrhages with surrounding brownish discoloration. This is minimal or small hemorrhages that can occur also in brain patient with hypertension. So this again, this is how does hemorrhagic stroke looks like. You can see there's a hemorrhagic or bleeding inside the brain parenchyma. So this is caused by the rupture of the vessels, in which being affected by the complication of the hypertension. So it can be atherosclerosis, it can be arteriolosclerosis, and when the blood pressure is high enough sometimes, so it can rupture these defects vessels that are in the brain and also elsewhere in the body. For the ischemic stroke, the usual part of the vessels that cause ischemic stroke is the lenticulostriate vessels, which arises from the middle cerebral artery. So these vessels usually you can see a lot of atherosclerotic plaque in these vessels. So when this atherosclerotic plaque is ruptured and thrombosis occur at the vessels, this will cause ischemic stroke in the patients. And sometimes if the infarction is small enough, you can see small or lacuna infarct in the brain. So as shown by the picture above. And apart from hemorrhagic stroke or ischemic stroke, another complication of hypertension in the brain is the hypertensive encephalopathy. So what will happen is this case usually occur acutely. So this occur when the diastolic pressure is more than 130 millimeter mercury. So this will cause increase in intracranial pressure and also global cerebral dysfunction. Patient can present with headache, confusion, vomiting, convulsion, and also coma. And brain, if you take a look grossly in the brain, there will be brain edema with or without any kind of brain herniations, either transtentorial or tonsillar herniations. It can be with or without this herniation. And petechial hemorrhage is also a common findings, and fibrinoid necrosis of the arterioles is also can be seen. So again, this if you compare the normal brain with the hypertensive encephalopathic brain. So in a normal brain, you can see, so you put side by side. On your left is the normal brain, on your right is the hypertensive encephalopathy brain. So in a normal brain, you can see the sulcus and gyrus is sulci and gyri is how to say well can be seen nicely. The sulci is the curve, and the gyrus is the elevation of the brain parenchyma. So you can see clearly the differentiation of the sulcus and gyrus, in which on the right side here you can see where the brain undergoes the hypertensive encephalopathy. What will happen is the brain parenchyma, or the brain outer part of the brain, becomes smooth, and you cannot differentiate between the sulcus and also gyrus anymore. This is because the brain becomes edematous. So when the brain is edematous, there will be increase in the intracranial pressure, and this will cause brain herniations, as seen in this picture. You can see subfalcine herniation, transtentorial, and also tonsillar herniation, in which the tonsillar herniation is the most fatal, because it can cause a patient to die due to this herniation, because at the tonsillar part over here is the respiratory and also cardiac center that control the respiration and also the heart rate of the person or patients. Alright. Okay, Durex hemorrhage is another findings if there is a tonsillar or transtentorial herniations. So here it is, the Durex hemorrhage inside the midbrains. Alright, a little bit on the investigation in hypertension. So what if you are asked regarding list down the investigation in hypertension to help you memorize or understand the investigation in hypertension, you can divide it into few groups. Number one, to investigate the etiology of hypertension, or the causes of hypertension. Number two is to screen for the complications, and the last one is to prevent the complication. To investigate for hypertension, what you need to some of the example of the test that can do is 24-hour urine VMA, hormones level, sleep study, and so MRI. Urine VMA is usually done to detect pheochromocytoma. Hormone levels is to see the levels of hormone, for example thyroid. If the patient having hyperthyroidism, of course the blood pressure will become increased. Sleep study to identify the patient if the patient is having sleep apnea or not. And last one is the MRI, just to see any brain lesions or the lesion in the abdomen that can cause hypertension to occur. To screen for complication is we need to do the fundoscopy, the renal function test, ECG, and so chest X-ray. The fundoscopy, of course, there will be retinal hemorrhages in cases of very high blood pressure. Renal function test is to see if there is if the hypertension affects the renal. ECG, the heart, to check the heart, and also chest X-ray also to see either the patient have or has left ventricular hypertrophy. And to prevent the complication, we need also to screen for serum cholesterol and also liver function tests, because cholesterol, of course, if the patient is having hypertension plus cholesterol, high cholesterol, so patient will start develop the complication of hypertension, for example atherosclerosis, ischemic heart diseases, sooner compared to the patient which has only hypertension, but the cholesterol is normal. Alright, with that, thank you and hope you can benefit from my lecture. So this is my Instagram, Twitter. If you have any questions, you can blast it or ask through the social media or my emails. Thank you.